Hi, welcome to NUR 303 Pathophysiology. This is Chapter 9, Gastrointestinal Function. This is one of 3 series again for this week. Okay, so the gastrointestinal system is also called the alimentary canal. It consumes, digests, and eliminates food. It includes the upper division, which is the oral cavity, pharynx, esophagus, and stomach. The lower division, which is small intestines, large intestines, and anus. And the hepatobiliary system, which is the liver, gallbladder, and pancreas. To reiterate here, the upper division is the oral, pharynx, esophagus, and stomach. The lower division is the small intestines, the large intestines, and the anus. And then the hepatobiliary, which is the liver, gallbladder, and then the pancreas, which is hiding here. And this would be the liver, gallbladder, and the yellow is the pancreas. So the gastrointestinal tract is charged with the task of ingestion of food, propulsion of food and waste from mouth to anus, secretion of mucus, water, and enzymes, mechanical digestion of food particles, which include chewing and mixing, chemical digestion of food particles, which would be enzymatic breakdown and acidic breakdown, enzymatic and acidic breakdown, absorption of digested food, and elimination of waste products by defecation. Except for chewing, swallowing, and defecation of waste products, the movement of the GI system are controlled largely by the hormones and the autonomic nervous system. So there's 4 layers. There's the mucosa, the submucosa, muscle, and serosa. Peritoneum is a large serous membrane that lines the abdominal cavity. And there's the parietal peritoneum, which is the outer layer, the visceral peritoneum, which is the inner layer, and then the peritoneal cavity, which is the space between the 2 layers, similar to what we talked about with the lungs, with the parietal and visceral layer surrounding the lungs. This is the same thing, only for the peritoneal cavity. There is a lubricant in there to make sure that there's no friction when there's, peristalsis going on, which we'll talk about in a minute. So there's movement all the time going on with your intestines, and so there's no friction. We have a bit of moisture and lubricant in there. Okay, here's a picture of the visceral layer, and the visceral, as I said, lines the organs, and then the parietal is on the outside. And so there's kind of like the whole cavity, and then in between them is the parietal cavity. The peritoneal cavity. So moving right along here, we talk about the mesentery. The mesentery is a double layer peritoneum containing blood vessels, nerves that supply the intestinal wall. And the mesentery is actually attached to the posterior wall. And what it does is the parts of the intestines, and I'm not going to name them right now, but they're suspended in these loose folds, and this is the mesentery. And it kind of looks like almost like a fanning mesh, and that and this mesh kind of attaches to the posterior wall of the abdomen. And what the mesentery is, it contains all these blood vessels and nerves that supply that intestinal wall. So it's very important, the mesentery is. And this is a picture, and you can see the different layers, the serosa, submucosa, mucosa, and muscularis, that is, part of the intestinal tract that we just talked about. And you can see also the mesentery that kind of feeds the blood vessels and the nerves to the gastrointestinal tract. The nerves are controlled by the local autonomic nervous system, and digestion glands, which are depicted here, the glands, may deposit substance into the lumen of the intestinal tract, which is the inside. Lumen is always the inside. Okay. So let's talk about the beginning here of our GI system, and that begins with the mouth. It's a reservoir for chewing and mixing food with saliva. We have taste buds that there's salty, sweet, bitter, and sour, and it helps with the enjoyment of food. It also helps to initiate salivation. We have olfactory nerves and teeth, and the teeth are used for mastication or breaking up the food, and that's important. Mastication is also called chewing, but that's a critical part of the starting the digestion process. There are 3 salivary glands that are critical at the beginning here: the submandibular, the sublingual, and the parotid. Saliva, there's about a liter made about a day, and it consists of water, mucus, sodium bicarbonate, chloride, potassium, and ptyalin. And that's an enzyme. Ptyalin is an enzyme. It's also called salivary alpha amylase, or ptyalin. And it's an important enzyme that it really starts the digestion of carbohydrates in your mouth and continues on through the GI tract, but it starts, carbohydrate digestion starts in your mouth. And if you chew a saltine cracker, which is enriched in carbohydrates, will begin to taste sweet, and you can tell this is kind of an example of the carbohydrate breakdown by that ptyalin. The saliva is controlled, saliva secretion is controlled by the sympathetic and parasympathetic fibers. So this is a picture of the parotid, submandibular, and then the all of the different salivary glands. So let's talk about the swallowing, or this part of it. The esophagus is a hollow muscular tube from the mouth and stomach. It's about 25 centimeters long. And peristalsis is a definition you should know. It's sequential contraction and relaxation. There's primary and secondary peristalsis. When we're talking about swallowing and we're talking about the esophagus, we have to talk about the upper esophageal sphincter. And this is a sphincter that's to limit air from entering the esophagus during respiration. So we don't want a lot of air going into the esophagus, because then it'll go into the stomach. And then there's the lower esophageal sphincter, which is also called the cardiac sphincter. And this prevents regurgitation from the stomach back through the esophagus. Swallowing is coordinated primarily by the swallowing center and the medulla. When you swallow, the lower esophageal sphincter is open, the cardiac sphincter. And when the stomach is full, the sphincter will shut. Now, the reason it's kind of important to talk about this is from neurological standpoint, that sometimes when there's neurological damage, like from a stroke or something, some of these mechanisms that are automatic have a hard time, functioning. And so our swallowing and all of these functions are disrupted. So when we talk about the phases of swallowing, we can talk about 2 of them. One's oropharyngeal, and that takes about a second. And this is food is segmented, and that's by chewing, mastication, and forced to the back towards the pharynx. The pharynx closes to stop the food from entering the nasal pharynx, and respirations are inhibited. The epiglottis then slides to prevent the food from entering the trachea and lungs. And sometimes, as I just said, we have pathologies that exist, like sometimes it's having to do with tissues, like musculoskeletal problems, and other times it has to do with like a neurological problem, like a stroke, where that whole oral pharyngeal phase is disrupted and swallowing is impacted. The second, and when that happens, a lot of times we do a swallow study as nurses, but sometimes speech therapists can be called in to do a more complete swallow study to see if their swallowing of somebody that had a post-stroke has a problem with swallowing. Because remember, if they're not swallowing properly, the food or water might be going into their trachea and they might be aspirating, and that's a problem. Esophageal is the second phase here, and this is when food enters the esophagus. The esophagus relaxes, getting ready for the food, and peristalsis moves the food to the stomach as the esophageal sphincter is relaxed. That phase takes about 5 seconds, 5, 6, 7, something like that. So the stomach is the next thing we're going to talk about. It's a hollow tube, muscular organ that stores food, secretes digestive juices, mixes with food with the juices, and propels the partially digested food, which is also called chyme. It starts being chyme in the mouth, and then it can, you refer to it as chyme all the way down the GI tract, the partially digested food. So it goes from the stomach to the duodenum or duodenum through the pyloric sphincter. So the pyloric sphincter is the sphincter from the stomach to the duodenum or duodenum. There are 3 muscles in the stomach. One's longitudinal, which is the outer layer. The circular is the middle layer, and the oblique is the inner layer. And you can see the longitudinal, circular, and oblique. The other thing I want to bring to your attention is the 3 parts of the stomach. There's the fundus, which is the top part, the body, which is a pretty long piece of the stomach, and then the antrum is kind of like the distal, if we call it the distal part of the stomach, the lowest part next to the pyloric sphincter, which kind of is the sphincter that allows the food to go from the chyme to go from the stomach to the duodenum or duodenum. And then there's these, the lining of the stomach is formed and with rugae, and that's what these are, rugae. And they are apparent with an empty stomach, so you can see the folds. But as the stomach fills, the rugae unfold and the wall stretches. Within the stomach lining, there's also acid that's produced for digestion and glands that are located in the stomach. So there's acid being secreted, but there's also glands in the stomach that coat the inner lining of the stomach, the inner lining, so that there's mucus for protection. And so, so we have acid, but we also are protecting our stomach with mucus. And that's when there's an imbalance of acid and mucus. That's when there might be some pathology, which we'll talk about in subsequent lectures here in this chapter. So let's talk a little bit about gastric motility. In a resting state, there's about 50 milliliters of fluid in the stomach. Swallowing creates the fundus to relax and to receive a bolus of food or chyme from the esophagus. Now, there's 2 hormones. They're called gastrin and cholecystokinin. They're polypeptide hormones that are secreted by the gastric mucosa. And gastrin stimulates hydrochloric secretion, and cholecystokinin stimulates the increase of secretion of alkaline pancreatic juice, which we'll talk about that in a minute. And also secrete bile and decrease GI mobility and increase the hormone, again, gastrin. So during this whole phase, we have several hormones here: gastrin, cholecystine, motilin, secretin, gastrin. Gastric mobility increases peristalsis. This is all kind of regulated by these hormones. Gastrin and motilin, which are intestinal hormones, and the vagus nerve increase contractions. Gastrin stimulates the increase or the release of hydrochloric acid. And the sympathetic nervous system and secretin, which is another intestinal hormone that stimulates the pancreas to release juices and the liver to secrete bile, work to decrease mobility. So they're increasing and decreasing. That's what the motility is. It increases at certain times and it decreases at certain times, depending on which hormone is secreted. Now, the movement of the gastric content into the duodenum depends on, sorry about that typo, it says into, it should say into the duodenum. It depends on the volume, what's in the duodenum, the volume, the osmotic pressure, which is also water regulation, and also the chemical composition of the gastric content. So the stomach secretes large volumes of gastric secretions. Now, the GI system is not sterile, and we know that because, what goes into it is not sterile. And G tube isn't, like a nasogastric tube, if you insert it into a patient, that's not sterile. Food is not sterile. And so there's a lot of things that go into the GI system that aren't particularly sterile. However, there's a lot of protection here. There's mucus that's secreted by the gastric lining that protects it. We have acid that dissolves food fibers, which is hydrochloric acid, but it also acts as a bactericidal against swallowed microorganisms. Now, we'll talk about this in a subsequent lecture, but there's certain things that happen that break these barriers of protection that include, like, ischemia. We talked about that word ischemia. That means a lack of blood supply. If there's not enough circulation going in there, then there might be a problem with the whole homeostasis of maintaining protection. There also people sometimes are exposed to H. pylori, which is actually the long name for it is Helicobacter pylori, which is a bacteria that disrupts that barrier. Also, nonsteroidal anti-inflammatories can disrupt the lining or inhibit certain protective syntheses of hormones, and can disrupt the protection and cause inflammation and ulceration. So a lot of things can disrupt this whole homeostatic protection. In this, for gastric secretion, we also have enzymes, which pepsin's one of them. It breaks down proteins. We have hormones, what we talked about in the last couple of slides, like motilin and gastrin. We have an intrinsic factor that's needed to absorb vitamin B12, and that's a very important vitamin. And we also have gastroferrin, which facilitates the absorption of iron, which is it's very important for hematopoiesis and red blood cell formation. So let's move on to the small intestines. The small intestines is about 5 to 6 meters long, and that's about 15 to 20 feet and about 2.5 centimeters in diameter. It's a site for about 90% of the nutrient absorption. It protects against infection. There is hormone secretion in the small intestines. There's a lot of complex signaling in the small intestines from the chyme in the presence in the duodenum. There's signaling to the gallbladder to secrete bile for fat absorption. And 90% of the water that enters the GI system is here. And so that's part of it as well. Now, when we start with the small intestines, the small intestine starts at the pyloric sphincter, and that's why I have this picture here. This is the stomach, but this is where the small intestines start. It starts at the pyloric sphincter, like after the pyloric sphincter into the duodenum, and that's the small intestines. So, and then it ends where the small intestines and large intestines meet, and that's at the ileocecal valve. There's 3 functional segments of the small intestines, the duodenum, and then it goes into the jejunum and the ileum. And then that valve that goes into the large intestines is the ileocecal valve. This picture I just want to show you right here. We have your duodenum, and then it goes into the jejunum. And then here is the ileum. It's all mushed up here, but here's the ileum, and then there's the ileocecal valve, and then this is the large intestines. Now, the other picture I want to show you, bring to your attention here is this, and this is called a villi, and this is in the small intestine, so we're still talking about small intestines. These are the functional units, and these villi secrete enzymes that are necessary for absorption. Now, you could see, and they're in these little finger-like things. See how many there are? There's a lot of them. And the reason they're up and down is so that their surface area is really wide, because it's all really compact, so that there's a lot of nutrient absorption that goes into these veins of the villi. But see how there it is right there. They're just all over. And you can see this, and we'll talk about this hepatic portal, says to the liver. We'll talk about that in a minute. That's the portal vein. Okay, let's talk about the large intestines. So the large intestines is where feces is formed. The chyme is massaged and water is absorbed. So the small intestine is really charged with the task of absorbing and nutrients and breaking down the digestion and absorbing nutrients. The large intestine really is charged with water absorption and electrolyte reabsorption. So we don't lose any electrolytes, and we don't lose any critical water. It's about 1.5 meters long, or 5 feet, The parts of the large intestines are the cecum, that receives the, it doesn't have a picture here, but the cecum's down here. The chyme from the ileum through the ileocecal valve, which we're not pictured here, but it's right around here. And then there's the appendix, which is really a vestigial organ, which means it doesn't do anything. It used to, I believe, be part of an infection control organ at one time, but it no longer is useful for a human. And then there's the ascending colon, transverse colon, descending colon. This is sigmoid, which we really talk about too much, and then there's the rectum and the anus. And that's the large intestine. The longer, remember, it's charged with the task of reabsorbing water. So if the food that's ready, the nutrients have been absorbed from it. Now we're just absorbing water in the large intestines. If the stool stays in the large intestines for a long time, water keeps getting reabsorbed from it, and so it becomes very, very dry, and so it becomes harder to pass as stool. And so we'll talk about that with constipation a little bit. Okay, so I don't want to do this too much. Okay, so here's the ileum, the ileocecal valve, the cecum, ascending, transverse, descending, and then rectum and anus. And you can see here's the portal vein, which we'll talk about in a little bit because this goes to the liver. This is really important because this carries things from the liver. And then I just want to bring your attention to there. Here's the aorta, and here's the inferior vena cava, because the inferior vena cava, remember, is taking the blood from the organs all the way up to the right atrium to exchange CO2 for oxygen into the lungs that we talked about with cardiac. Okay, so the large intestines. Defecation is stimulated by a movement of feces into the sigmoid colon and rectum. There's a defecation reflex. There's internal anal sphincter relaxes, leading to the urge to defecate. However, you can voluntarily override this by contracting the external anal sphincter and muscles in the pelvic floor. So, although there is an urge to defecate, you can voluntarily override it. There is another word I'd like you to know, and that's the Valsalva maneuver. And that is a maneuver that is done where you hold your breath and force the diaphragm down and the chest muscle against the closed glottis to increase the thoracic and intra-abdominal pressure, which is transmitted to the rectum. And Valsalva maneuver helps with defecation and passing of stool, but it also is used a lot of times. We tell our patients to perform a Valsalva maneuver for whatever reason, and that's what they do. They hold the breath and bear down, and that's a Valsalva maneuver. So this is just a picture about where things are absorbed, water and alcohol, and duodenum is charged with absorbing a lot of things, and so is the jejunum and ileum. And then the colon, of course, is water and electrolytes. Very important. So let's talk a little bit about intestinal bacteria. Now, the intestine is colonized about 3 weeks after life, and with E. coli and Clostridium welchi and Streptococcus. The environment of the stomach is relatively sterile. Okay, like the things we put in it are not sterile, but it's relatively sterile because of the acid that's there. Bile acid secretion, motility, and antibody production keep the bacterial numbers in the duodenum to a minimum as well. And then there's a low concentration of aerobes in the jejunum. Anaerobic bacteria are distal to the ileocecal valve. And the ileocecal valve is past the small intestines, it's in the large intestines. And the anaerobes are 95% in the fecal flora or in the colon. So most of our bacteria is in the colon or the large intestines. Now, that's why when, and remember I said E. coli is one of the bacteria, and that's why a lot of times when somebody has a urinary tract infection, by and large, many times it's E. coli that's the bacteria that's causing the urinary tract infection. The E. coli is from the large intestines. Okay, let's talk about some accessory muscle or accessory organs. We're going to talk the liver, the gallbladder, and the exocrine pancreas. All secrete substances necessary for digestion of chyme. And these secretions are delivered to the duodenum through the sphincter of Oddi. So here's our liver, here's our pancreas, and that's our gallbladder. And I want to say that the liver produces the bile, and which contains salts that are necessary for fat digestion and absorption. And between meals, the bile is stored in the gallbladder. Now, the exocrine pancreas, this is a familiar picture to you. Now, we'll go over this when I talk about pancreas in a couple slides. But the exocrine pancreas produces enzymes. The exocrine, the endocrine pancreas has the beta cells we talked about, and endocrine, the endocrine system. The beta cells secrete insulin and then make sure that the glucose goes into the cells. But the exocrine part of our pancreas is charged with providing enzymes for complete digestion of carbohydrates, proteins, and fats. It's very essential. That's why the pancreas is such an essential organ as well. And also it produces an alkaline fluid that neutralizes the chyme. And creates a duodenal pH that supports enzymatic action. And as you can see here, it goes out through it connects at the common bile duct here, or sometimes it can go out through this duct here directly into the duodenum or join the common bile duct. Okay. So this is the liver anatomy, and we're going to talk about liver real quick. Now, I'm not going to, I'm going to keep all of the functions in the slide presentation so you can read it. But I'm not going to talk about all the functions, but there's about 400 functions to liver. It weighs about 1,200 to 1,600 grams. It's in the right diaphragm. There's 2 lobes covered by the glycan capsule, which contains blood vessels, lymphatics, and nerves. It's a very vascular organ. It has a lot of venous blood going into it and a lot of arterial blood going into it. The functional units of a liver are called hepatocytes. They're capable of cell division and readily reproduce when there's needed to be replaced by damaged tissue. If the liver tissue is damaged, they can replace to a certain degree. And that's why somebody with a pathological liver like cirrhosis, that's a scarred liver, and the hepatocytes are not functioning correctly. But if you have an injury to your liver or the transplant, if somebody's got a transplanted piece of a liver, that's why they can do that, is because the liver will regenerate itself, and that's what the hepatocytes can do. There's a portal vein, and the portal vein, you can see hepatic portal vein is right here, and that's a very low pressure going into the liver, delivering blood into the liver, and I'll talk about that in a minute. And then there's a hepatic artery. This is the oxygenated blood that actually gives oxygen to the liver tissue or hepatocytes and takes away CO2. And at any one time, there's about 30% of cardiac output in the liver. So it's a very vascular organ and very helpful if the body needs blood. For some reason, the liver will give up some of the cardiac output to help with the blood, to maintain cardiac output. For the rest of the critical organs, which the critical organs pretty much are the brain and the heart. Okay, we'll talk a little bit about what the liver can do. First of all, it's charged with lymphocytic capabilities. It has these phagocytic von Kupffer cells that remove foreign substances from the blood. What happens is, remember we talked about the red blood cells and how they break down every 120 days? Well, when they break down, there's hemoglobin and there's heme and then there's globin. We keep the heme because we regenerate that, but the globin is broken down into bilirubin. And bilirubin, in the way it is at bilirubin, if it stays in bilirubin, it's very toxic to the body. So it has to be converted to conjugated bilirubin, and then urobilirubin. Well, the liver is charged with the task of converting it to conjugated bilirubin to urobilirubin so that it gets excreted with the stool, which gives stool its color. The urobilirubin gets it the color. And also urine, some of it goes into the urine. So that bilirubin breakdown that's what one of the charges of the liver is. It can also store large amounts of glucose as glycogen, and this normalizes the blood sugar levels when we need it. In fasting times, so it stores glucose. It also can, in fasting times, the glycogen can be broken down so that glucose is released and being used for the body. And it can also, it synthesizes, breaks down, and stores fatty acids and triglycerides. It forms bile, which we'll talk about in a minute, about 700 to 1,200 milliliters a day, which if it's not used at the time it's produced, it's stored in the gallbladder for fat breakdown. And then through the sphincter of Oddi, the bile is distributed. And then another thing bile is for fat metabolism. So really, if bile is made in the liver and it's made for fat metabolism and stored in the gallbladder, then the liver is very, very important for fat metabolism. It's also really important for protein metabolism. When we talked about vasculature, we talked about protein molecules that kind of keep the fluid inside the vascular system. Well, one of the big protein molecules is albumin. Albumin is manufactured in the liver. And if we don't have albumin, that's why we have leakage of intravascular volume to the extravascular volume where there's edema, because albumin holds the blood in the circulatory system. The liver also synthesizes clotting factors, and the clotting factors include growth hormone, fibrinogen, factors 1, 2, 7, 9, and 10. It's also bile is needed for absorption of vitamins, which include vitamin K, which is also important for clotting. So if there's a dysfunctional liver, then we would have clotting disorders. The liver also breaks down amino acids for protein synthesis. When amino acids are broken down, they're converted to carbohydrates, and then there's a byproduct of ammonia. And the liver gets rid of the ammonia, and it's actually converted to urea and excreted through the kidneys. And when the liver is not functioning correctly, this excretion of this highly toxic ammonia builds up. And so the liver is charged with the task of getting rid of the ammonia. And also, it synthesizes non-essential amino acids that are created by the body and not obtained by food. And they're essential for wound healing, cellular function, removal of toxins. And the last thing is, it's very important for storage of vitamins and iron. Now, that's just a handful of things that the liver does, but that's why it's such a critical organ. I mean, that's why when you have liver failure, it affects so many things. Okay, so this is a basic structure of a liver lobule, and you can see all the little hepatocytes. They're all lined up here. Okay, the liver is constructed of lobules, which are composed of hepatic plates. And the liver, one of the big things the liver does is manufacture bile, and that's what these little green things are. This is like the vein that, like the little ducts, caniculi, that houses the bile, and then these are the bile ducts that it actually goes into. And then you can see here that there's the hepatic portal vein, and we'll talk about that in a minute. And then the hepatic artery, which actually gives the hepatic cells oxygen and takes over CO2. And remember, when I talk about the liver manufactures the bile caniculi enter into the terminal bile ducts into the duodenum. So it's all right. They're all together. You don't necessarily need to know this. What I wanted to show you is how complex this clotting cascade is. And there's at least 6 factors that are, I think I say 5 factors that are manufactured by the liver. And that's why if you have a problem with your liver, that's why there's clotting disorders. You bleed. Oh, okay, this is a hepatic portal situation. I just want to go over this real briefly to let you know that the liver receives blood from both arterial and venous sources. The hepatic artery, which isn't pictured here, but the hepatic artery comes off the abdominal aorta, and it provides oxygenated blood for the liver. And it also takes away CO2, so it oxygenates, just similar to what the coronary arteries do for the heart. That's what the hepatic artery does for the liver. Now, there's venous blood that drains from the stomach, the small intestines. So all this here's, I don't think the stomach is here. Oh, there it is. It's just a partial stomach. Stomach, small intestines, large intestines, pancreas, which is a piece of pancreas here, and spleen, and the spleen is over here. And what it does is the venous blood drains from all these essential organs, and it goes into the liver through the portal vein. And that's what this is. It says portal vein, the portal vein. And this is where all this nutrient-rich stuff goes into the liver, where it pulls out things that it needs to make the bile, to make the proteins, to make everything. And so it pulls out all of the nutrients that it needs to do. And then what happens is, after the blood, the arterial blood takes away the CO2, and then this hepatic, all of this venous blood is getting done. The hepatocytes are done with them. Then it goes, this kind of used blood, where it's ready for reoxygenation, goes up through the inferior vena cava, and then it goes to the right side of the heart, or the right atrium. So the secretion of bile. Bile is an alkaline, bitter-tasting, yellow-green fluid that contains bile salts, cholesterol, bilirubin, electrolytes, and water. Bile is formed by the hepatocytes, and it's secreted into the bile caniculi, to the hepatic duct, to the common bile duct. And then it goes into the small intestines, and it's stored in the gallbladder if it's not used. And it's used for fat digestion. So what's the gallbladder? The gallbladder is a sac-like organ that lies on the inferior surface of the liver. The function of the gallbladder is to store and concentrate bile between meals. It holds about 90 milliliters. It begins to contract after eating under the influence of the vagus nerve and some more hormones that we talked about before, cholecystokinin and motilin. Okay, let's talk a little bit about the pancreas now. So we talked a little bit about the endocrine function. We all talked about it with a previous slide, and we also talked about it earlier in this semester. Endocrine is, the function is from the beta cells, and that secretes or makes insulin. But the exocrine is from the acinar cells, and the acinar cells produce amylase and lipase. Okay, and we talked about this down. These are essential for digestion. It produces these amylase and lipase, and also produces an alkaline solution that consists of all these electrolytes. And so the alkaline solution and also enzymes of amylase and lipase are produced by these acini cells in the exocrine function of the pancreas. The water is necessary for digestion as well. So let's talk about aging and the digestion function. Well, when we age, just like everything else, things wear down. Tooth enamel and dentin wear down. Teeth are lost. Ill-fitting dentures may affect eating, which is something we consider with our patients. Sometimes there's periodontal disease, gum recession, osteoporotic bone changes, all which might affect mastication. The number of taste buds declines, sense diminishes, so the enjoyment of eating sometimes declines. Salivary secretions decreases, which then might promote periodontal disease and also problems with that initial carbohydrate breakdown in the mouth, and decreased esophageal and gastric mobility. Also, atrophic gastritis, gastritis just due to all the protective mechanisms in the stomach being there may not be as active as earlier in life. So there might be gastritis, B12 deficiencies, decreased digestion, liver experiences reduced blood flow, delayed drug clearance, and so diminished regeneration capacity. That all happens because your liver is, I think it reaches mature, like a mature liver, I think at about 21 years of age. And then subsequently, regeneration of everything slows down as the person ages. There's changes in lactose, calcium, iron, metabolism, and absorption. And there's also decrease in peristalsis. So there's a few terms I want to talk to you about here is in clinical manifestations, gastrointestinal dysfunction. One is anorexia. Anorexia is a lack of desire to eat or loss of appetite despite physiologic stimuli that would normally produce hunger. Anorexia nervosa, on the other hand, is a psychological, physiological syndrome characterized by a distorted body image and fear of being obese. And that's just, anorexia can be caused by somebody just not wanting to eat because of medication or disease process. But anorexia nervosa is generally a psychological condition. But anorexia can be exhibited by a lot of our patients. Cachexia is a syndrome that includes anorexia, early filling, like you feel like you're full when you're not really. They only feel like, if they eat 2 bites of a food, I'm full. Weight loss, anemia, weakness, and basically wasting away. That's what cachexia is. And vomiting is forceful emptying of the stomach, intestinal contents through the mouth. It comes with strong abdominal contractions, forcing ejection of chyme. There's several types of stimuli that initiate the vomiting reflex. When you vomit, you take a deep breath. Your glottis closes, the soft palate rises, respiration cease to prevent risk of aspiration. That's just your normal protective component of your body. The gastrointestinal sphincter relaxes, abdominal muscles contract, forcing the chyme into the esophagus, and reverse peristalsis ejects the chyme out of the mouth. And that's the step of vomiting. Some more terms: nausea is a subjective experience that's associated with a number of conditions. It's a sensation of impending vomiting, and it's a common symptom of vomiting are hypersalivation and tachycardia. If that's how people feel if they're nauseated. Now, retching is non-productive vomiting. There's there's nothing that's coming up. Projectile vomiting is spontaneous vomiting that does not follow nausea or retching. It's generally very quick and it's forceful. And the projectile vomiting, the reason it's called projectile is truly is projectile. It's very forceful and it's very strong. And a lot of times the vomitus will be projected in a very long distance. And a lot of times projectile vomiting is associated with a head injury or and other pathologies. So when we talk about when someone's got a head injury, a traumatic brain injury or a head injury, and they have certain characteristics, one of the things people, nurses and healthcare providers look for is projectile vomiting for these folks. Okay, vomiting may be preceded by nausea or retching. Recurrent vomiting can be exhausting and can lead to fluid and electrolyte and pH imbalance. This is really important to know. So somebody is continent, and it really can lead to dehydration. It can also be associated with aspiration, that if you vomit and aspirate, it can cause serious damage to the lung tissue, and can occur when you're supine, unconscious, or the vomiting or cough reflex is suppressed. And actually, aspiration pneumonia or aspiration vomiting is very dangerous, because when you aspirate the content into your lungs, you have to realize that there's acid that also goes along with it. So aspiration pneumonia develops with these folks if they vomit and aspirate their vomitus. Hematopoiesis is blood in the vomitus, and it has a characteristic of coffee ground appearance, which is like a blackened appearance, and it's resulting from protein in the blood being partially digested. And so that's how you know it's, coffee ground or bloody. Bloody, when it's overt blood, like red blood, a lot of times it's esophageal bleeding, but a lot of times if it's coffee ground in appearance or dark, then we know it came from the lower GI tract or, from the stomach or lower. Blood inherently is incredibly irritating to the gastric mucosa. So if somebody is bleeding gastrointestinally, they will vomit, or most people vomit, and they can lead, and it can hematotemesis. It can occur from any condition that causes GI bleeding. Okay, vomiting can be yellow or green. It usually indicates, if it's that color, presence of bile. It can occur as a result of a GI tract obstruction, obviously, if you have yellow or green vomitus. A deep brown color vomitus may indicate the content, if it's not bleeding, it's dark brown, not because black is indicating that there's blood in there. But if it's brown, it might be indicating that there's it's from the lower intestines or fecal material. Many times it's odor, it has an odor as well. And this can indicate a intestinal obstruction. If you have undigested food vomitus, this is caused by conditions that impair gastric emptying. And when you diagnose vomiting, it's a history, physical, blood chemistry, and a lot of times it's visual as well. For vomiting, you might give an antiemetic or an anti-nausea medication. A lot of times if somebody is vomiting, many times you give them, if they're in the hospital, you give them intravenous fluid. Correct electrolyte imbalance that could be apparent. And also, if you remember, the hydrochloric acid is in the gastrointestinal tract, and if you're vomiting and get rid of the acid, then a lot of times you'll have pH problems with your blood as well. So that's a metabolic, like pH problem. Constipation, here's the next one. This is a change in bowel pattern characterized by infrequent passage of food, stool, or defecation in reference to a person's typical bowel pattern. So everybody's constipation isn't the same. It just depends on your bowel pattern. What happens with constipation is stool remains in the large intestines longer than usual, and the water is removed, and it becomes increasingly firm and then harder to pass. A lot of times a low-fiber diet, inadequate physical activity, and insufficient fluid will, and all the other things that are listed here, may cause constipation. There's a myriad of things that can cause it. And it also can be caused, children sometimes are, when they're being toilet trained, will become constipated because it's almost like they're not used to controlling their bowels. Constipation can manifest in pain during passage of bowel movement, inability to pass after straining and pushing for more than 10 minutes, no bowel movement for 3 days, or hypoactive bowel sounds. And this is all diagnosed, through physical assessment and things. Complications can be anal bleeding, of course, if there's passage of a hard stool. Anal fissure, which is like a split in the anal canal, and bleeding. pH disturbances, hemorrhoids can be a problem from chronic constipation because you're constantly trying to bear down, and there is a problem with the vasculature down there. Diverticulitis, impaction, that's when there's a large bit of stool that cannot be passed. Intestinal obstructions, and then fistulas, which is between two compartments, there's a hole or a connection. Diagnosis, you can have history, like you do a pattern, how, your bowel movement pattern, you follow that. Physical examinations, abdominal x-ray, upper GI. Abdominal x-ray is a lot of times what they'll do first, upper GI series, colonoscopy, where you actually a lot of times go in rectally and take a scope and look at the colon, or proctosigmoidoscopy. Treatment would be increasing diet, fiber, hydration is very important, increasing physical activity, defecating when the initial urge is sensed instead of waiting. Treatment is stool softeners, of course, limiting use of the laxatives if it's chronically being used, and digitally removing the impaction if it's necessary, and also determining your routine of bowel routine. The next one is diarrhea, and this is a change in bowel pattern characterized by frequency, amount of water content in the stool. Results because of increased fluid secretion, decreased fluid absorption, and alteration of GI peristalsis. Acute diarrhea can be caused by viral or bacterial infections or certain medications. A lot of times acute is self-limiting depending on the cause. Chronic diarrhea is lasting more than 4 weeks, and it can be caused by inflammatory bowel disease, malabsorption, endocrine disorders, chemotherapy, and radiation. It really does. Chronic diarrhea is caused by a lot of different things, and equally as much. If diarrhea is originally in the small intestines, the stools are large, loose, and provoked by eating, and they're usually accompanied by pain in the right lower quadrant. But if they're in the large intestines, the stools are small and frequent, and they're accompanied by pain and cramping in the left lower quadrant. Acute diarrhea is generally infectious and accompanied by cramping, fever, nausea, and vomiting. Now, there's diarrhea that you might watch out for any kind of stool. If it's frank blood, that's frank means it's visible. Occult means it's microscopic. And melena is black tarry stools. So that's how we classify them. Is the blood, when we describe it, we say it's frank blood or it's melena blood. I mean, it's frank. The stool had frank blood in it. The stool was black and tarry. And sometimes there's pus and mucus as well. In diarrhea, bowel signs might be hyperactive. And again, with diarrhea, like vomiting, you have to worry about fluid, electrolyte, and pH imbalances. Because if you're losing a lot of fluid that way, because remember, if it's going out through the colon and it's not being reabsorbed, the water's not being reabsorbed and near the electrolytes, then we might have fluid, electrolyte, and pH balance problems with diarrhea. So how do we diagnose it with history? You do a bowel pattern, documentation, physical exam, stool analysis. A lot of times they do cultures in occult blood, and they'll send to the lab the stool to see if there's any blood in it, complete blood count, blood chemistry, and so diarrhea treatment, fasting for acute diarrhea with infection origins. So you just make sure that they get fluids, but don't feed them, make them NPO, nothing by mouth. Antidiarrheal agents may or may not be used depending on the cause, because you don't give antidiarrheals if someone's got certain GI infections. Antibiotics might be necessary. Anticholinergics would slow down the diarrhea. Antispasmodics, which are pretty much symptomatic to stop the spasms. When oral intake is recommended, a clear diet is started at the beginning, and then you advance as to a regular diet as tolerated. Dietary fiber can be used to manage chronic diarrhea, but that's just one mode that might be used. Maintaining hydration is very important, correcting electrolyte and pH. Meticulous skincare is incredibly important for someone that's incontinent of stool and is maybe not really mobile, because diarrhea can break down skin very quickly. So the clinical manifestations of gastrointestinal dysfunction are abdominal pain. Abdominal pain is a symptom of a number of gastrointestinal disorders. You can have parietal pain from the peritoneum, which can be intense. Visceral pain from like an organ, distension or ischemia. Ischemia, again, is a problem with the blood distribution to that organ. Referred pain is pain felt at a distance from a diseased organ. Like, for instance, cholecystitis, it's the inflammation of the gallbladder. Sometimes you can have pain in the right shoulder. That's referred pain. That's what referred pain means too. And that is it for this lecture. Thank you.